Hi Ninja Nerds, in this video we are going to talk about asthma. So let's go ahead and get started. Alright, so let's go ahead and get started on asthma. So first off, how would we define asthma? Let's just get a basic definition of it. Okay, before we start going into all the pathology and the underlying etiology, the first thing that you want to understand is it's a chronic inflammatory condition, and it's characterized by having the narrowing of the respiratory passageways, which can cause difficulty breathing. Sometimes it can even be extremely fatal. So that's a simple definition of asthma. It's just basically a chronic inflammatory condition of the respiratory passageways, particularly the mucosa, that causes the narrowing of the respiratory passageways to the point where it can become difficult to breathe and sometimes can become fatal. Now, what are some of these underlying causes? Well, we don't really completely know what is the underlying etiology of asthma. We know that there's some type of genetic predisposition possibly through it. And it's related through a specific type of triad. And what we call that triad is called the Atopic Triad. So the Atopic Triad is, there is certain individuals who have some genetic predisposition, okay, where they have more of allergic or hyperresponsiveness to specific types of allergens. What are these three conditions of this Atopic Triad? Well, one is going to be asthma. The other condition is going to be atopic dermatitis. Atopic dermatitis is also called eczema. We'll write out the particular name though, atopic dermatitis. And the last condition that is going to be a part of the atopic triad is going to be allergic rhinitis, okay? Allergic rhinitis. These three conditions are the genetic predisposition. Might have a family history, they might have some underlying genes that make them more predisposed to responding in such a way to particular allergens that cause them to produce massive amounts of inflammatory mediators that produce this exacerbation or bronchospasm of the actual respiratory passageways. So these are some of the big ones. So this is more likely to be the genetic predisposition of asthma, okay? So again, individuals with the atopic triad as a genetic predisposition, so maybe they have allergic rhinitis, maybe they have atopic dermatitis or eczema or asthma, this is usually the underlying genetic predisposition associated with it. So they have that hyper-responsiveness. The other thing is it could be related to something really interesting, which we call the Samters Triad. So the Samters Triad. And the Samters Triad is three different things that makes these individuals more susceptible. One of the big ones for the Samters Triad, again, we know that this is association with asthma, nasal polyps, and here's the big one, aspirin. We're going to write that as ASA, aspirin sensitivity. What do I mean by this? In some individuals, they might have kind of an allergic or hypersensitive reaction to aspirin. What do I mean? Well, you know aspirin, if we actually talk about the arachidonic acid pathway, so you know you have arachidonic acid. We're just going to put AA here. Arachidonic acid goes through two different pathways. One is it can go through a pathway which is utilized by the COX enzyme, so cyclooxygenase enzyme. The other one is it might go through a lipooxygenase pathway. The lipooxygenase pathway leads to the formation of leukotrienes, and there's many of these different types, okay? So if you wanted to know some of them, there's leukotriene B4, there's leukotriene C4, leukotriene D4, leukotriene E4. There's so many of these, and all of them have specific functions. Usually leukotriene B4 is a pretty good chemotactic agent, and leukotriene C4, D4, and E4, these are the culprits behind that intense bronchospasms, okay? The other pathway is for the cyclooxygenase pathway. This leads to the formation of prostaglandins, and there's many of these. There's PGE2, PGI2, PGF2, there's many of these. All of them have, again, multiple different functions. But here's the thing. In some individuals, they have this situation where they have a sensitivity to aspirin. Where aspirin, you know what it does, right? It actually inhibits the cyclooxygenase enzymes, which are responsible for converting arachidonic acid into prostaglandins. For some reason, whenever these individuals take aspirin, it inhibits this pathway in such a way that it actually can start tipping the balance and shunting the arachidonic acid into the leukotriene pathway. Why is that important? What did I tell you was leukotriene C4, D4, and E4 responsible for? Bronchospasm, increased vascular permeability, and it also can cause a lot of mucus production within the airways. Those are the big morphologies that we're going to see when we talk about asthma, particularly when we get down into the bronchi or the bronchioles, okay? So those are the big things here. So again, asthma, it's a chronic inflammatory condition characterized by narrowing of the air passageways. What could be the causes? It could be underlying genetic cause. So it might have a genetic predisposition, especially in individuals who have atopic dermatitis or eczema, allergic rhinitis, or asthma. Could be related to some other underlying mechanism, specifically to aspirin sensitivity. And also make sure that you look in, because sometimes patients who have aspirin sensitivity might have nasal polyps or asthma. And the reason why this is important is because with aspirin sensitivity, it can tip the balance by inhibiting the COX-2 or COX-1 enzyme, which aren't able to make prostaglandins. And then it shifts it into forming leukotrienes. And the big ones that you got to remember is C4, D4, and E4, because these are the ones that produce intense bronchospasms. Okay? But there's many other situations that could exacerbate asthma or cause it to, come about. What are some of these triggers? Well, one of the big ones is usually like certain types of dust. So one could be dust. So dust mites, could be pet dander. So it could be pet dander or pet hair. It could be due to bugs, cockroaches. Cockroaches are actually been found to be able to be an exacerbating factor. It could be due to cold, and it could even be due to exercise. So sometimes exercise can even be related to it. Here's another really big one though I want you to remember. Usually viral upper respiratory tract infections. This is a big one. Sometimes when somebody actually develops a viral URI, it can actually trigger an exacerbation of asthma. That's a big one. And sometimes even emotional stress. Another one that I want to mention is smoke, right? So not just dust, but even, don't forget, smoke inhalation. So for like tobacco, right? Tobacco smoke or certain types of air pollutants. Another medication that has actually been found to do this, to trigger the asthma, is not just aspirin, but sometimes even people who are taking beta blockers. Why? Because beta blockers actually respond by binding to beta receptors. Well, guess what kind of beta receptors are present on the smooth muscle within the actual bronchioles? Beta 2. So if somebody has a beta blocker, the epinephrine or the norepinephrine, which is normally binding onto the beta 2 receptors and promoting bronchodilation, is going to be blocked. And what's that going to do? It's now going to lead to bronchoconstriction. So that can cause an exacerbation of asthma as well. So to recap, all of these exacerbations and triggers could be atopic, genetic, could be due to medications like aspirin sensitivity related to the Samters Triad or beta blockers. It could be related to certain types of chemicals like dust, pet dander and hair, cockroaches, cold, temperatures, exercise, viral upper respiratory tract infections like the common cold, and smoke inhalation, whether it be through tobacco or certain types of pollutants. Now, these are some of the things that we know are responsible and as well as triggering asthma. What we need to do is we need to go into this a little bit more and talk about the molecular mechanism, because we've kind of come to an understanding of how the molecular mechanism works. So what we say is, again, let's say that there's some type of predisposition, okay? And what happens is, let's say that there's a particular allergen, okay? So here, we're gonna have here, this is going to be the allergen. Maybe it's dust, maybe it's mold, maybe it's something of that nature. This allergen is going to come into contact with specific types of antigen-presenting cells. What are those antigen-presenting cells? One of the big ones that you guys should know about is called your dendritic cells, but even macrophages. So here, look at this guy. We draw the dendritic cells because they have multiple different cytoplasmic extensions. But here's a dendritic cell. What a dendritic cell will do is it'll phagocytose these allergy-like particles. When it phagocytoses it, so here, let's write that down there. It undergoes phagocytosis, and it also is going to activate particular genes. On chromosome number 6, there's the MHC2 molecules. it'll actually take phagocytose it, break it down via the phagolysosome mechanism, activate the MHC2 complexes, and express that allergen with an MHC2 complex on its cell membrane. So now look at this. We're going to have an MHC2 complex. Let's do this in purple. So here, he's going to have a MHC2 complex here. Here's our MHC2 complex. And again, what's expressed on that is we're going to have that actual nice little allergen. So here we're going to have the allergen. That dendritic cell then takes this actual MHC2 complex with the particular allergen and brings it to a T helper 2 cell. So let's draw a nice little T helper 2 cell in here. Let's do this guy in this dark green here. So here, we're going to have a T helper 2 cell. Look at this guy. What does a T helper 2 cell express on its cell membrane specific to this? One of the big things is it has a CD4 molecule. And another thing that it has on its membrane is a T cell receptor, which is particular to a specific foreign antigen. Now, this T helper 2 cell will react with this dendritic cell. So let's bring this dendritic cell down here to react with this guy. Here's our dendritic cell. And again, what do we have here? We're going to have the MHC2 molecule. And on this MHC2 molecule, we're also going to be presenting what? We're going to be presenting that foreign antigen, which is this allergen, which is going to bind with the T cell receptor. Whereas the CD4 molecule is going to interact with the MHC2 molecule. Now, upon this interaction, the T helper 2 cells undergo a inappropriate type of reaction in a way, because again, of this underlying condition, underlying genetics or even environmental relationships. And what it does is it produces two really important chemicals. What are these two chemicals? One is called interleukin 4, and the other one is called interleukin 5. Interleukin 4 is really important. What interleukin 4 does is it actually activates our plasma cells. So let's do here, we're going to have, it's going to activate the plasma cells. So this is going to be our plasma cells with a nice rough endoplasmic reticulum. So the interleukin 4 is going to be released. Here, let's actually do this like this. We'll have interleukin 4 being released, and that's going to act on these plasma cells. When it acts on the plasma cells, it's going to stimulate the plasma cells to produce specific types of antibodies. You know what specific antibodies it actually produces? IgE antibodies, and it produces a lot of them. These IgE antibodies then go and bind onto particular cells, and guess what these cells are? These cells are called mast cells. So now we're going to have here mast cells. The mast cells have a specific protein on their membrane called an Fc epsilon R1 receptor, Fc epsilon R1 receptor, which binds with the IgE antibodies. Then, once this IgE antibody binds here, it then can trigger the mast cell to undergo degranulation. When it degranulates, it starts to produce massive amounts of histamines, and it produces a lot of leukotrienes. Again, there's many of them. We've already talked about them, but these we know are inflammatory mediators. That's the first response. The other chemical that we mentioned here is going to be interleukin 5. So interleukin 5, guess what this guy does? Interleukin 5 goes and activates a particular white blood cell that we know has two really important functions. One is we know it's related to killing parasitic worms. The other one is we know it plays a complex role in allergy and asthma. Well, guess what that guy is? It's an eosinophil. So now here we're going to draw a red structure here. It has a bilobe nucleus, which kind of looks like glasses. Look at that. Look at, he's chilling. Here, we'll put the glasses there, all right? And then you're going to have the granules, which stain red because of the eosin that they apply via the right stain. Now, the interleukin 5 is going to activate this eosinophil. So again, what is this guy here? This is a eosinophil. This eosinophil is then going to release leukotrienes. And it's also going to release other cytokines, which are going to attract in more white blood cells. But you know what else it can do? Which is very important. It can also release specific types of proteases. And these proteases, over time, chronically, can start to produce tissue damage to the respiratory tract. So this is really important, especially in chronic cases. But what I want you to remember for right now in the acute response is leukotrienes and other cytokines that help to attract in more white blood cells, particularly more eosinophils. Now, from here, these histamines and these leukotrienes, what do you think these puppies are going to go do? They're going to go affect the actual bronchioles. So now look here. We have these histamines. We have these leukotrienes from both the mast cells and from the eosinophils going where? Affecting the bronchioles. Okay, all of this is actually happening in the actual submucosa, the mucosa area of the bronchioles. Now, again, over here, what do we say from the aspirin sensitivity? Excuse me, via the Samters Triad. We know that the leukotriene C4, D4, E4 is pushed to making more of those, especially with people who have aspirin sensitivity. So again, from this one, you're going to have a lot of leukotrienes coming here and acting on these actual bronchioles. Isn't that beautiful? It should make sense now. Because we know that leukotrienes and histamines, what are they going to do? Well, if you remember histamines, I want you to remember the big thing with histamines. One thing is it normally produces smooth muscle relaxation, right? But in this case, for the respiratory smooth muscle, it actually causes constriction. So one of the big things that's going to happen here is it's going to cause bronchoconstriction. So let's write this down here. Let's do this one in this brown. So we know the first thing that's going to happen is there's going to be bronchoconstriction. Now this is a really big one. Bronchoconstriction is whenever the smooth muscle is going to contract. They're going to be hyperreactive. They might even over time become hypertrophy and even hyperplastic, which means you can make more of them or the cells get bigger, right? So hyperplasia, you make more of them. Hypertrophy, they actually get bigger. That would be over chronic periods of time. But bronchoconstriction is going to narrow that airway pretty bad. The next thing is histamines also cause dilation of the capillaries and cause increased capillary permeability. So what else are you going to get here? You're also going to get a lot of increased vascular permeability and a lot of inflammation. Guess what that actually helps to stimulate? A lot of mucus production. So then, on top of the bronchoconstriction, you're going to get a lot of mucus buildup here because it's going to increase the vascular permeability as well as try to dilate the actual capillaries in this area. So then you're going to get mucus buildup. So that's another big one. So bronchoconstriction and mucus buildup. What else? Another thing is we also said that this mucosa is going to become super inflamed. It's going to fill with a lot of fluid. So that's another thing is you're going to notice that this actual mucosa here, which you're going to have your epithelial tissue is the first part of the mucosa, then you have your lamina propria. Well, you're going to start filling this with a lot of fluid. So now the mucosa is going to become filled with fluid and some eosinophils and other different types of inflammatory exudate. So you're going to have a inflamed, right, mucosa. And again, we said that the leukotrienes that I want you to remember with these guys is they help to be able to promote bronchospasm. They also cause mucus buildup. They also cause the inflammation of the mucosa. But again, one more thing that we can't forget is there's going to be an increase in vascular permeability. Okay? So these are the things that we're going to see. So there's going to be constriction. There's going to be mucus buildup, which is also going to be narrowing the airways. There's going to be inflammatory exudate due to the increased vascular permeability and immune cell infiltration. That's also going to narrow the airway. So all of that should make sense why the airway is actually narrow. Now, this is usually in an acute response, right? But over time, over chronic, consistent exposure and this chronic exacerbations, it can become fibrotic. So over time, now generally, here's what you want. I want to write this down actually, very, very important. Asthma is reversible. So in other words, you take away the trigger or you treat them with the appropriate medication, it can be reversed. It can go right back to normal. And the respiratory passageway can actually not cause this intense bronchoconstriction. The mucus buildup will go away. The mucosa will no longer become super inflamed. The vascular permeability will go back to normal, right? But again, I want you to understand, over chronic terms of this consistent exacerbations of asthma, it can become fibrotic, it can scar, there can be thickening of the basement membrane and become permanently narrow. That is no bueno. We don't want that, okay? So that's an important thing to understand. One last thing I want to mention before we end the pathology and move into the signs and symptoms is there was one more thing that they've related asthma to be due to. And again, it's controversial, but they relate it environmentally to what's called the hygiene hypothesis. And again, they're still kind of like working this whole theory out. Hygiene hypothesis. This is specific for late onset asthma. Usually, because asthma is mainly having a genetic aspect via the atopic or via the Samters Triad, this hypersensitivity, that usually helps us to diagnose it before the age of 12. But with environmental, it's usually a little bit later. Now, what does this mean? Hygiene hypothesis says that people who have had reduced exposure to bacteria or viruses or pathogens, they are more likely or more susceptible to develop asthma later on in life because of some type of effect on actually the maturation of our actual white blood cells. Okay, so that's one theory that they've gone through, but again, this is more for the later onset of asthma. All right? So that's the pathophysiology of this. The next thing we're going to do is we're going to go over the signs and symptoms. All right, listeners, so in this video, we talked about the pathophysiology of asthma. I know we talked about a lot of stuff. I hope it made sense. I hope you guys enjoyed it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. In the next video, we're going to go over a lot of the actual diagnostic workup, a lot of that protocol, being able to figure out, is this asthma or is this something else? Okay? If you guys like this video, again, hit that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, go check out our Instagram, our Facebook, even our Patreon account. If you guys have the opportunity to donate, we would truly appreciate that. Also, down in the description box, we'll have a link to our GoFundMe page if you guys would be willing to donate anything there. It will help us to continue to keep making videos, as well as purchasing equipment, books, all the different necessities that we need to make these videos for you guys' enjoyment. All right, engineers, as always, until next time.